Okay, let's see how this works. Okay. It's a real honor to get to do this. And obviously all of us across the country are watching very carefully what's been happening, not just in New York City, but throughout the East Coast. And hopefully you feel our support from a distance. I was asked to talk about radical cystectomy for high-grade T1 urothelial cancer. Next slide, please. And just by way of disclosures, do a fair amount of clinical trials, both in non-muscle invasive cancer and invasive bladder cancer. And we have a couple of clinical trials in the Southwest Oncology Group supported by Genentech and JBL, which is the Tokyo strain of BCG. I do some consulting, patent on a TA subtype classifier. I don't think much of what I'm going to talk about is relevant to this, but if it is, I'll point it out. Next slide, please. So this is what I'm going to cover. We'll talk about risk stratification, importance of re-resection in high-grade T1 disease, who are the ideal candidates for initial cystectomy or cystectomy as the first treatment, and then we'll talk a bit more of an obvious situation with radical cystectomy for persistent or recurrent T1 disease, a little bit about outcomes, and then I'll finish with some sort of interesting genomics work. Next slide, please. For risk stratification, it's really critical to get an accurate assessment of stage and grade before determining appropriate therapy. So I put in here that T1 is always high grade and therefore high risk. There are these occasional patients who have a T1 low grade tumor. I think they're pretty rare. May be a reflection of the change in the grading system where about 4% of grade 2s were reclassified as high grade and 60% low grade, and this may be where this comes up. So it does have an occasion, but I think for discussion's sake, I'm really going to be confining this to the overwhelming majority of patients who have high grade disease. There is a category of very high risk, and this would be multiple or large high-grade tumors, multifocal CIS, and particularly CIS in the prostatic urethra, because that's a reservoir for CIS that really can't be treated with BCG without a formal bladder neck resection. And this is particularly important to patients who have evidence of recurrence after treatment with BCG, because obviously in men, the prostatic urethra is this reservoir not going to be reached by the BCG. You have to sample the prostatic urethra in patients who have evidence of recurrence after BCG. And this would usually be evident by a unexplained positive cytology, for example. And then variant histology, and particularly micropapillary, is an aggressive variant of high-grade disease. And these patients, I think most of us feel like ought to be treated with upfront cystectomy. You can advance to just, yep. We'll talk a little bit about substaging. There's been a lot of work done in this area, and I'll highlight a paper by Bas van Ren from the Netherlands next. And I think it's really important to understand that you can't accurately stage T1 disease without detrusor muscle in the specimen. I'll show you a slide illustrating that next. And then I guess I would have to say put all in parentheses in terms of re-resection. We'll talk a little bit about the evidence around this. It's in all of our guidelines. And you always want to err on the side of re-resection. I'll just give you an example of, I'll give you a couple of cases, but a lot of times, you resect the primary tumor and then you find out that it's a high-grade T1 disease, but you haven't really sampled the rest of the bladder. So about 30 to 40% of patients will have associated CIS, blue cystoscopy, fluorescent cystoscopy. This is a sweet spot for detecting CIS. So there's other benefits to going back and re-resecting, in addition to the obvious one of making sure you've removed all the papillary disease, that there's no persistent high-grade disease, there's no evidence of deep invasion, but also to sample the rest of the bladder looking for CIS now that you know that you have a high-grade cancer. Next. So a little bit about substaging. So this is the work from Bas van Rijn, European Urology. It's been out quite a while, but he's been a real student of this. And you can see in the top panel, these are photomicrographs from his paper. T1M would be sort of minimal or microscopic. It's a single focus. They use a measurement of 0.5 millimeters or less and find a one high power field. I think if you look closely, you can see the microscopic invasion between the two papillary folds, as opposed to the bottom. There's easily established invasion of the lamina propria, and this would be more extensive, either in one large area or multiple areas. Next slide, please. So he looked at this in just Kaplan-Meier, and you can see the way the plot is organized, that blue is microscopic or micro, minimal, and the brown is established, and you can see the clear difference in PFS. And these were all primary T1 tumors. Next. And then in a multivariable analysis, you can see extent of invasion of the lamina propria, T1M versus T1E, had a profound independent impact on both progression and disease-specific survival, advance. And in summary, they found that this was a better method of stratification versus an older T1 ABC. The nice thing about it, because you're essentially measuring things under the microscope, it's independent of the identification of blood vessels, which are apparent in mucosa is the muscularis mucosa. And there's been a lot of studies discussing about the presence of that. 70% of bladders, looking at the lamina propria, and so this is just a nice reproducible way, at least in their hands. So I think the take-home message is that extent and depth of invasion into the lamina propria appear to have an independent impact on outcome. Next. So I'll throw some things, pearls in throughout the talk, as I was asked to do. So quite a long time ago, we were trying to figure out we were a smaller institution at Baylor in the sense that the volume of patients that we were seeing. So our consortium together, the Bladder Cancer Research Consortium, to kind of pool our data. So this was Baylor, UT Southwestern, led by Yara Lotan, and Hopkins, led by Mark Schoenberg and Pierre Karakiewicz, who did his fellowship at Memorial, was our biostatistician. We published a lot of papers with that consortium. It was made up of about 900 plus, in this case, really radical cystectomy. But the point that I wanted to make here is you can see the impact of the presence of carcinoma in situ in patients otherwise who had clinical T1 tumors. So the message here is that you really sometimes have to look for this, and CIS is often going to be adjacent to the high-grade T1 tumor, but can also be remote. And so what I like to do is classify and if I'm doing sort of site-specific biopsies, specify what's adjacent and what's remote, and make sure I sample the rest of the bladder. Now, there's some caveats to that. For instance, like the two patients I did TURs on yesterday, they all were referred with the probable need for cystectomy, but one in particular, a guy on end-stage renal disease on dialysis, had such large volume disease it really didn't matter biopsying the bladder. The guy needs a cystectomy, and he's an example of a patient that needs an upfront cystectomy with T1 high-grade disease. Next. So I'm going to throw in a bunch of cases. These are all patients that I've taken care of over the years. 64-year-old lady, 3-centimeter tumor right lateral wall inside the bladder. Slice from the CT scan, completely resected, T1 high-grade disease, muscularis propria not involved, normal bimanual, standard of care re-resection, and no residual cancer, which was good. So we've got her accurately staged as a T1 high-grade, and no evidence of CIS on site-directed biopsies. So next. So this patient would fall into the category of high risk, but not very high risk. Standard of care re-resection is negative, and you can kind of flip through the options here. If you just hit next, see that we treated her with BCG, standard of care. And I realize the talk's about cystectomy, but I think in order to understand who should get a cystectomy, we also need to understand who can be treated with BCG next. So it's important to understand the guidelines and the AUA. I don't know if it's released yet. I guess it'll coincide with the what was going to be our annual meeting. Have updated the non-muscle invasive bladder cancer guideline, and standard of care would be BCG plus BCG induction plus 3 years of maintenance, acknowledging that probably about a third of patients get to 3 years. Some of that's due to toxicity, some of that's due to recurrence. And obviously some of that's due to BCG shortage. And in times when there's been a BCG shortage, like now, although it seems to be easing, well, not like now, we've been through once before, some patients were getting upfront cystectomy simply because they had high-risk disease and couldn't get BCG. EIU randomized clinical trial also supports 3 years of maintenance in patients with high-risk disease, and it's also important to understand the NCCN guidelines because this is often what we have to show to third-party payers to get approval for our treatments next. So SWOG 8507, and what does 8507 means? That the trial was initiated in 1985. So that was, I guess, a year after I graduated medical school. Just shows you a little bit of how old I am. And this was the trial that established the 3 years of maintenance. So it was a randomized trial of induction alone, just induction plus 3 years of maintenance that used a different strain that we don't have available today in anywhere, actually, is the Connaught strain. There's some data to suggest that Connaught may be better than Tice, and that data really is in patients who only get induction. But the take-home message from this trial was that there was a statistically significant improvement in both recurrence-free survival and progression-free survival. Though the margin of benefit on the PFS side is small by the Kaplan-Meier plot, it's a very clear indication of the ability of BCG with all comers with high-grade disease to improve the long-term outcomes. The substantive difference in recurrence-free survival is obviously a lot bigger. But what I want you to take a look at is just say, take the 5-year mark, so the hash mark between 48 and 72, and you can see the portion of patients that are recurring and progressing. And the reason I point this out is that it requires really vigilance on our part to stay after these patients, keep them in our practice. I'm sure that you've seen many, many patients like I had that got out to 3 years of BCG. They're doing great. A year or two later, they recur in the bladder, they recur in the prostatic urethra, they recur in the upper urinary tract. And these are patients that simply require lifelong surveillance. The duration of time that you do cystoscopy after 5 years, I generally tend to stop, but I keep them in the practice to keep an eye on them, doing voided urine biomarkers. And then the duration of doing cross-sectional imaging is also variable. I certainly don't do it after 5 years, but I do keep them in practice next. So the critical time point in a patient who's been treated with BCG is 3 months. So that's 6 weeks after the induction therapy. And if you just look at let's talk about the patients with CIS, because I've kind of had to adjust what I do. I used to take patients to the OR at the 3-month mark and do biopsies under anesthesia to sort of pathologically stage the response. But we know from this trial that a proportion of patients who get the 3-month maintenance will the CR rate goes up by about 20 to 25%. And even without the 3-month maintenance, you'll see about 10 to 12% of patients with induction only who will clear CIS without additional treatment at 6 months. So these are the data that have been with us for a long time, getting this right. So at 3 months, office cystoscopy, cytology, if you're doing additional biomarkers, that's fine. And if those are all negative, go on to 3-month maintenance. And then at 6 months, so after 6+C, in patients with CIS, we restage all those patients in the operating room. And again, if you have access to blue light cystoscopy, that's where the sweet spot is too. Next. So here's another case. This is maybe a little bit easier. 62-year-old female, 1.5 years ago, she had a high-grade T1 tumor re-resection, was negative, got standard of care BCG plus maintenance, and then got referred to me now with recurrent high-grade T1 and CIS. And I think there's really only one correct answer here. Next. But I threw up these options. One of the messages with BCG is if you've had an interval of greater than 12 months since the last BCG, and the patient otherwise has a cancer that you'd feel comfortable treating, you can reinduce these patients. Sometimes we'll add interferon, but I think in this case, the best treatment option, because it was relatively soon, 18 months from her initial diagnosis, next, would be radical cystectomy. So here's a scary kind of situation that I think is obvious. So a very healthy 57-year-old has, and I think that this T1 high-grade multifocal CIS falls into our high-risk category, sort of maybe borderline for a very high risk. It would depend upon whether the high-grade disease, whether the T1 disease was multifocal or large volume. But his urologist gave him the option of proceeding with BCG. He came to see me. I said, no, we got to take you back to the operating room first. Next. Which is what we did. And you can see why it's critical to do this. And I think that there's data out there to show that even if you were the one who did the first surgery and you say, oh no, I got it all into fat, got everything, you got it. And this is the reason that you have to take them back. So, this patient obviously went on to get standard of care neoadjuvant chemotherapy and a radical cystectomy, and he's done fine since then. Next. May have put the pathology up. No, I didn't. Okay. So let's talk a little bit about re-TUR and recurrence. There's a kind of data out there. The take-home message is this is an important next step in virtually all patients. And I was looking down at the table and I'm just looking at the labels, and it's a little, to me, it's a little hard to interpret. But I think the message is that the difference in outcomes with and without re-TUR, the green is the re-TUR, the blue is the no re-TUR. And you can see that this persists over a very long period of time. And there's a huge drop-off if you look initially at the first 5-month time point in the no re-TUR. And this should be pretty obvious because those patients have likelihood of having residual disease. Next. So there's been a randomized trial. A lot of us like to use this paper, this trial as another example. We like level 1 evidence. This was not as clean a study as you'd like, but it clearly shows the benefit of a re-TUR. and persistent over time, as you can see in the plot on the left and the Kaplan-Meier plot on the right, highly statistically significant. Next. And I think there's another, yep, I think next. And this is just overall survival with re-TUR. So what I teach our residents is you'll never regret taking the patient back. Now, in our setting, as yours, a lot of these patients are either being referred from the outside or seeking a second opinion. And so I think it's important if you're the one who did the original TUR, I always take those patients back, whether it for any patient with high-grade disease. But it's also, obviously, I've made the point already that if you're the one who did the original TUR, you got to take them back. Next. So this is obviously 2001, a much older paper, and this shows the importance of having detrusor muscle in the specimen with high-grade T1 disease. These were patients that I believe all went on to get a cystectomy, so you've got accurate pathologic staging. But one of the concerns that I have about retrospective studies like this, and I'm not criticizing these particular investigators, it's just something to recognize in patients with clinical T1 that, so for instance, the other guy that I operated on yesterday had tumor-associated hydronephrosis. So he had a nephrostomy tube put on the right side. I took him back. He was referred to me by one of our outside urologists who's part of our group out in the periphery. Couldn't get a stent in, so I took him back, and I was actually never able to find his orifice, but the pathology from his first resection showed T1 high-grade disease. So he doesn't have clinical T1 disease. He's got clinical T3 disease, completely independent of whether or not the pathologist was able to identify that. And so I think some of those patients ended up in this trial or this cohort. And so I think the important thing is to get muscle in the specimen initially and put all of the information you have available to you from the CAT scan, from the EUA, from the presence of tumor-associated hydronephrosis, which is most frequently associated with pathologic T3 disease. Next. And this is a paper, I'm sure, hopefully everybody in New York is familiar with this. So this is work from Ida Dalbagni and Harry Herr, the Memorial Series, showing how the impact of, now I've done my restaging, and Harry was always, probably still is, adamant about restaging everybody because he also was very intrigued by the so-called radical TUR and the ability to treat some patients with invasive bladder cancer with just TURBT in a highly select group of patients. So he's got this wonderful series, but here it shows you that when you take the patient back and there's persistent high-grade T1 disease, that it has a pretty significant impact on outcomes. So those patients are also ones that you have to think about upfront cystectomy. Next. So this is back to our Bladder Cancer Research Consortium, and this is just our T1 series. These were all clinical T1s, and you can see that the percentage of patients that were upstaged by either PT stage or node stage had the obvious impact on outcome long-term. So upstaging at cystectomy has a profound impact. I'll come back to this very quickly about the importance of doing a cystectomy before a patient develops muscle-invasive bladder cancer. Next. So here it is. So this is one of many papers that have looked at this. You know, I hear a lot, or I heard a lot, that, you know, cystectomy, you have to have muscle invasion. And so this shows very clearly the impact of doing a cystectomy at the appropriate time. I don't really like the term early. It's really treatment that we choose for or recommend for our patients, and waiting for absolute evidence of muscle invasion to pull the trigger on a cystectomy, you're going to end up with something like this on the right. The patient's going to sacrifice some survival benefit in the long run. So the best thing that we can do is identify those patients before they have muscle invasive disease, identify the patients who are unlikely to be controlled long-term with BCG, and then do an appropriate cystectomy as their form of therapy, rather than waiting. Next. There you go. That's the take-home message there. Just another more recent paper analyzing this same issue, and it's stratified by whether or not they had a TUR and whether or not there was muscle in the specimen. And you can see from these various Kaplan-Meier plots, here's time to recurrence. It's a little, to me, when I look at this, it's a little all over the map, but if you look at the blue line at the top, and these are no muscle, no re-TUR. And I hope for, if you take away, hopefully you'll take away a few things from this, but that's really a recipe for long-term disaster. No re-TUR and no muscle in the specimen. Next. We can just kind of, here's time to progression. Here's no muscle, the brown line, which is the worst outcome, no muscle on a re-TUR. Next. And the impact on survival. Again, you can see, now these plots are overlapping, and you might look at that as skeptic and say, doesn't really seem to make much of a difference, but this is a retrospective cohort, and there's always going to be limitations to those types of analysis. Next. Okay, so I'm going to show you two patients who I've operated on in the last couple of months. Again, as illustrative cases, 55-year-old grossing year, but he's a never smoker, so he has no risk factors. Obviously, the gross hematuria should have been worked up a long time ago. And he, on CT, had a large tumor in right-sided and a right lateral wall diverticulum. So I would argue that if you look at the CT, I apologize, this was an outside scan, so I didn't have it in my pocket to pull up the images. You'd probably look at that CT, recognizing that it's in a diverticulum, and conclude that he needed a cystectomy. And I think that would be appropriate, really just based on the CT. But I went in and did a TUR. And he had not just the disease in the diverticulum, but he had a lot of multifocal disease sort of adjacent and remote. And this was all T1 high grade, muscle in the specimen, not involved. And then the disease in his diverticulum, at least the pathology that I got, was TA high grade. I couldn't resect it. I'd made a decision that he needed a cystectomy, and I think I've got the path here. Next. Oh, good. Okay, so the question is, I'm just going to throw this in because I think some of you may know that this is another area of interest of mine. We've got a clinical trial in the South Oncology group that's completed accrual, randomizing patients to extended versus standard node dissection. We've just completed about 3 years of follow-up, and it's not ready to report yet. Hopefully you're aware of the German clinical trial that studied this as well, and it was a negative trial. So the question here is, I've got a clinical T1, and obviously everybody should get a standard node dissection, would be external iliac, internal iliac, and outflared lymph nodes bilaterally. But the question is, do you need to extend the node dissection higher? People refer to as an extended node dissection, maybe up to the aortic bifurcation. If you look at the clinical data, the clinical trials that have looked at this and mapping studies, the incidence of positive nodes with pathologic T1 high-grade disease is probably in the less than 10% range. And virtually all of those patients who have positive nodes, it's going to be in the standard template. So in a case like this, unless I see something intraoperatively that makes me concerned, say, let's say I had a suspicious lymph node and maybe I did a frozen section in the standard template and that was positive, I'd certainly go up and do an extended node dissection. But he did not. Here's the pathology, which may not come as any surprise to you. Go ahead. So we had a PTA in the diverticulum. Well, why is that? Because obviously there's no, in an acquired diverticulum, there's no detrusor muscle. So if it invades all, it gets into the fat and hence PT3A, so it was microscopic. I think we did a pretty good job at removing all of the potential lymph node bearing tissue. And then the question comes up, we're not going to get into this today, whether he should get adjuvant chemotherapy. We're not going to do that in this case because of the microscopic involvement and the completeness of the node dissection. We'll see how he does long term. I think that hopefully this would be an obvious situation where all of us would recognize that this patient needs cystectomy. Now the next patient, go ahead, about the same age. He had a very, sorry about the noise in the background, very large tumor in his bladder, former cigarette smoker, so that's his risk, had a TURBT with variant histology. So this is confirmed by our pathologist looking at the outside slides, 10% micropapillary, no LVI, re-resection by me, same pathology. So here's our, this patient falls into the very high risk category because of the papillary component. Many people have tried to address the issue about, does it matter how much micropapillary is there? And I think the answer to that is we don't know. Next. And again, the extended node dissections. I think my argument here would be the same. I felt confident that this was likely to be no worse than a PT1 because of the re-resection. Next, here's his pathology. So TA high grade, so that's good. So we only had residual non-invasive cancer. I paid the pathologist extra money to find out more lymph nodes. This is clearly exceeds our normal, but I think the point is that a really thorough anatomic node dissection, you can give the pathologist the best opportunity to identify potential metastatic disease. So these two patients, I think, really represent probably fairly easy decisions about doing upfront cystectomy, because if you don't control the disease at this point, the likelihood of progression and subsequent mortality, I think, is too high to take that risk. Next. So I'll just throw up everything there. I think I've got another, just advance it so everybody can see the whole slide. Okay, so just in summary for this part, in this situation, when you have progression of T1 disease from TA or TIS, and the presumption is that they've had BCG, those patients, I would say standard of care is cystectomy. And then for patients who have an initial presentation of a high-grade T1, all the things that we've talked about. I think the other thing is this is a study looking at lymphovascular invasion. So I touched on it briefly about you should be able, there's blood vessels within the lamina propria. Here's an example of a micrograph on the right showing what I think most pathologists would have a very easy time recognizing of cancer cells within an endothelial line space. There's immunohistochemical markers which can help identify that, and you see the profound impact on lymphovascular invasion. So it is a priori requirement for the pathologist to describe whether or not there's lymphovascular invasion in the pathologic sample. And just because it's T1 and you don't see it, you need to refer to the pathologist and say, hey, you didn't comment on presence or absence of lymphovascular invasion, and it's really important for my decision-making to know that. So the absence in a pathology report with any invasive cancer, T1 or greater, of any comment about LVI should prompt a phone call to the pathologist to go back and take another look at it. Next. Go ahead, next. Yeah, you can, is that, oh, please make sure your microphone is muted, or is that to me, Gina? Okay, so here's some strong indications for upfront cystectomy. I've talked a lot about micropapillary disease. Got it, note to the audience, thank you. And the other thing that's really quite interesting is Luan, who's a pathologist at Methodist Hospital, where we used to do most of our work, has published on this and has shown that the majority of patients with micropapillary disease have lymphovascular invasion. It's relatively straightforward for the pathologist to identify. I think most of us have recognized that we see a bit more of this over the last 10 to 15 years when it was first called to our attention from the group MD Anderson. Next. And then small cell, I think, is what I have up. Yeah, so small cell neuroendocrine is also a relatively straightforward pathologic diagnosis. Even if it's a T1 high grade with small cell carcinoma, we'll treat those patients with neoadjuvant chemotherapy, and then most of them should get a cystectomy. Radiation is an option in this particular setting of small cell. But I think for the most part, standard of care would be neoadjuvant chemotherapy. We use a slightly different regimen that's used in small cell of the lung. That would be etoposide platinum. Next. And you can just throw up the rest of the animation. These other histologic variants, which I find are quite uncommon in T1 high-grade disease, but if you do see them, these would be other variant histology indicators to proceed with initial cystectomy. Next. Okay, so this is a paper that I would encourage everybody to look at. This is was published a few years ago in JCO. It's often quoted because I think that it's very comprehensive and very well done, and obviously in a high impact journal. It's not something that urologists necessarily read routinely, the urologic oncologists do. You can see the depth of their study of this meta-analysis of 73 studies. And again, you see the recurrent themes, the depth of invasion, lymphovascular invasion, presence or absence of CIS. You can look at the forest plots on the left and identify those that are significant that don't cross over the line running down the middle at 1. Larger tumors and for some reason or other older age also fell out in their analysis. So this is probably about as good as it gets from a quality standpoint of a meta-analysis. And meta-analyses of randomized clinical trials or even phase 2 trials qualify as level 1 evidence. Next. And this is another sort of look at this from obviously a very large cohort, 2,500 patients, limited by its retrospective nature, but again, focusing on the topic today of T1 high-grade disease, and in their multivariate analysis, also age fell out, tumor size, and whether or not they had maintenance EG. I think there's next. Yeah, and so what they identified these risk factors, then developed a model from anywhere from 0 to 3 of the adverse risk factors, and you can see kind of what you would expect, that the more risk factors you have, the worse the outcome, in this case, time to progression. So if you had particularly an older patient, larger volume tumor, and in this case did not have maintenance ECG, for instance, then those patients would be at higher risk for subsequent progression. Next. And you can just throw up both. This is, we had a nice sort of debate at the SIU in Athens back in the fall. I came across these two algorithms from highly reputable teams, and you can kind of pick whichever one you like. They're complicated, but if you let's just kind of take the one on the left. In the box that says RETUR, consider random bladder biopsy, I would remove the consider. I would use that opportunity when you're going back to absolutely map out the bladder. There's no real indication for biopsying the prostatic urethra at the initial presentation, but definitely in a patient who recurs after BCG. And then you can see in their algorithm if that resection has less than T1 disease, I think it would be obvious you go on to BCG. If they have T1, then consider cystectomy, but we've got a number of patients, I'm sure you all do as well, where that resection shows minimal T1, and I'm very comfortable treating those patients with BCG, particularly if they're a little higher risk for a cystectomy. And then on the right side of that, if they have multiple high risk factors or even one very high risk factor, which they call variant histology LVI. Now, I would say that nephrosis that's tumor associated, in other words, T1 high grade with hydro, is more likely a TB. But the other thing that you have to be very careful about is making sure that they don't have a ureteral tumor causing the hydro. So you get in there and you're not really convinced that the high-grade T1 tumor was causing the hydronephrosis, you've got to do, you look at the upper urinary tract, retrograde, do a ureteroscopy, whatever you need to do to prove that there's no tumor in there, because that obviously changes your management. And then a little bit more complicated algorithm on the right, but I think that these are good ways to, when you're particularly learning how to take care of these patients, these algorithms can be quite helpful. Next. I've shown this already, so we can go to the next slide. And this is just, these are Kaplan-Meier plots from a paper in 2012 showing essentially the same type of analysis: immediate cystectomy, conservative management versus delayed radical cystectomy. This is a comparison of initial versus conservative management, and you can see that the initial cystectomy, at least on the right, had a better outcome in the more contemporary series. Next. And then this is the comparison of immediate to delayed. I think in this situation, it didn't have a negative impact on outcome. And I think this is going to be largely a reflection of how vigilant we are in following these patients very carefully. And if we can do that, they're compliant, and we pull the trigger, so to speak, on a cystectomy at the first sign of recurrence of high-grade disease, and they're going to have a good outcome. Next. Okay, so I've got a couple of slides on genomics, and then hopefully we'll have minutes for questions. I think some of you know that one of the best things I've gotten to do in my career was co-chairing the analysis working group for the Cancer Genome Atlas Project, muscle invasive bladder cancer, and I've been on the steep part of the learning curve for quite a long time. But I pay attention, I think, to this field quite a bit. And the group from Lund, Sweden, were really the first people to comprehensively look at the genomics of bladder cancer. They had it across the entire spectrum. They've got just an absolutely phenomenal paper trail, and their focus is largely on transcriptomics, but they've also done a very nice job of translating that into things that most of us can understand a little bit better in terms of immunohistochemical markers, focusing on a handful of genes. You can see the bottom panel: FGFR3, TP63, ERB2 or 2, for instance. KRT5 is a primitive cytokeratin associated with basal tumors. But what they did is they took a group of T1 high-grade disease, much like we've been talking about. And if you just look on the right, that their urobasal group had the best outcome, genomically unstable, and squamous cell-like had the worst outcome. And that's reflected in a number of markers that are very easily done within a pathology laboratory. Expression of FGFR3, for example, would be trying to look at what the comment is, would be associated with luminal papillary disease, which has a much better outcome. Next. Yep, that's just another from the Kaplan-Meier plot, showing the outcome. So this is a fantastic prospective study from Lars Durskott, who's been a pioneer in transcriptomics of non-muscle invasive disease. And they have a uromole, what they call uromole group, which now has over 3,000, I believe, prospectively collected tumors. And this is a paper that was published in 2016 in Cancer Cell. And they did unsupervised hierarchical clustering and identify 3 clusters, and you can read along some of the covariates on the right. Remember that yellow is high and blue is low. So they looked at obvious things of tumor stage, tumor grade, size, growth pattern, concomitant CIS, CG, and for those of you who are not familiar with looking at heat maps, if you just advance the animation, this is the summary from there. Whoa, something happened. Lost the animation. What you see in class 3 is basal-like tumors. So in muscle-invasive cancer, about 30% of those are basal tumors, which are associated with less differentiated cytokeratins and benefit from neoadjuvant chemotherapy and also immunotherapy. It's interesting that you can see these subtypes in non-muscle invasive disease. Next. And there's a very nice paper from Eugene Pietzak. Eugene, if I've boogered up the pronouncement of your last name, I apologize. He's obviously from New York, comparing low-grade and high-grade disease. And if you just look on the right side, the high-grade T1s are in yellow. So if you look at grade and stage, you can see that they had a nice representation of high-grade T1 disease. And you can see some of the genes that were altered in those patients. And particularly, they have an interest in DNA damage repair gene alterations. They've shown that those patients are more likely to respond to cisplatin-based neoadjuvant chemotherapy. And you can see some of that data on the bottom right. Next. And just kind of this is, I think, the last genomic slide also from Eugene. And this has been very intriguing to me because they compared patients who had a primary muscle invasive bladder cancer, a little bit outside the bandwidth of what we're talking about, and secondary MIBC, which are by definition progression. And the vast majority of those patients had BCG. And the suggestion in this paper is that ERCC2, the canonical DNA damage repair gene alteration, was present only in the primary muscle invasive bladder cancer. So there's some suggestion that patients who progress from non-muscle invasive disease, the presumption is they've been treated with BCG, may be less likely to respond to neoadjuvant chemotherapy. That needs to be tested and validated. Next. Let's go ahead and advance. I think we'll wrap it up. Yep, next, I think I've got a summary. Yeah, so just kind of throw this up. These are the guidelines. I think we've kind of through this in detail. You can go ahead and cycle through the. The EIU guidelines are relatively harmonized in recommendations for upfront cystectomy. These, again, just for the audience, large tumor size, high grade is all we've been really talking about. Sometimes difficult to access tumor location, like example of a tumor diverticulum, multifocal disease, presence of CIS, lymphovascular invasion, and then particularly in the patients who recur after BCG, you got to look at the prostatic urethra. And then next. There you go. So that's the take-home message. We talked about T1 substaging and the importance of this. Who should get front cystectomy, and then patients who don't have any high-risk features and no T1 on re-resection, they can be treated with BCG induction. Standard of care is maintenance as long as they're responding and not having any toxicity. And then think very seriously about the patient who has persistent T1 high grade on re-resection or recurrence after BCG. That's radical cystectomy would likely be the standard of care. So that wraps it up. I really appreciate it. Sorry for whatever technical difficulties, but I'm happy to take any questions.
Dr. Lerner, thank you very much. This is Miata, one of the other residents that's helping with this series. Thank you, honestly, for this guideline and evidence-based, management approach for these T1 non-muscle invasive tumors. One of the questions we had from one of the first questions we had was an individual asked if you had done imaging prior. Clearly, the imaging had shown T3 or locally advanced disease. You had a large bladder lesion. You went in for TURBT, resected, but you didn't get muscle in the biopsy. Would you proceed to like a re-TURBT to confirm, or would you counsel the patient and just say, hey, look, I think it's safe to say we can take the bladder out?
Yeah, it's a really good question. I'm concerned if it's tumor-associated hydronephrosis, then by definition, that's a muscle invasive bladder cancer. I gave you a couple of caveats where that might not be the case.
Mm-hmm.
And it also depends a bit on who did the resection. So if it's a patient who's being referred in, I gave you an example. I mean, I take those patients back to the operating room and restage them myself. But if you did it and it's tumor-associated hydronephrosis, they basically need a cystectomy. The argument, though, too, is they probably need neoadjuvant chemotherapy. So the other thing that I teach is that the goal of the TURBT, obviously, is stage and grade and histology. But that's probably not a patient that's not someone I would call clinical T1,
Mm-hmm.
call them clinical T3. Yeah.
Gotcha. This is a question that I had was, does any of these advanced cystoscopic, like narrowband or Cysview with blue light cystoscopy, does that fit anywhere in your algorithm for TURBT or, yeah?
Yeah. So there's just to be clear, the FDA approved indication is not for muscle invasive disease. It's for non-muscle invasive disease designed to detect additional papillary or CIS lesions. So the sweet spot is at the initial diagnosis. So I think most of these patients, we're going to do a cystoscopy in the office. If we say, okay, I think this is a non-muscle invasive disease, then we'll use blue light on every single patient. We have Olympus scopes in the office, so by definition, we've got narrowband imaging. We use that with the flexible cystoscopy. Fluorescence is now approved for use with flexible cystoscopy if you have that capability in the clinic. But yeah, we'll do it, and particularly if it's a patient who's referred from the outside, I'll use it in those patients. For the reasons I mentioned before, to really get a feel for the adjacent and remote mucosa, presence or absence of CIS.
Great. Another question was presented was, are there currently is there currently any role for molecular subtyping or any other tissue-based biomarker for clinical risk stratification for T1 disease?
The short answer is no, or maybe not yet. So be on the lookout for a paper that's under revision by Josh Meeks. Some of you may know Josh, did his fellowship at Memorial, brilliant MD PhD at Northwestern. He's got a cohort of about 70 high-grade T1 tumors that he's done a very deep dive in transcriptomics, and there's going to be some interesting hypotheses that come out of that. He and I and others have been talking about how to do a clinical trial in the Southwest Oncology Group using a risk stratification model that builds in genomics. That's clearly the future. I mean, I think that all of us, scratch our heads all the time about the biology of these tumors. And, who can I safely treat with BCG? Who needs a cystectomy? Because we've all seen this blow up in our face. We thought we had it right. So I would say stay tuned, and I'm hopeful that in the next few years we can do clinical trials to test and validate genomic predictors. Yeah.
Great. Well, just for the sake of time and respect for everyone's time, including yours, just want to thank you again so much for being a part of this Empire lecture series. It was a pleasure to have you. For anyone that tuned in late, the recordings will be available in a few days, hopefully, if not later this afternoon, on our website. So tune in, and if you have the opportunity to fill out the survey, we'd love to have all and every possible response to kind of improve this program that we have. Dr. Lerner, thank you again so much for this very in-depth review, and we hope to have you again sometime.